77 years old male with epigastric pain and anemia, submitted to gastroscopy with an ulcer from the gastric corpus, adenocarcinoma, and CT scan showed a thickening of the gastric wall and calcified nodule of the right liver, liver met or hydatid cyst, US for staging.
My colleague Nick is going to start by showing you endoscopically the lesion, so if we can move to the endoscopic view.
So, hi. Thank you very much for this opportunity to show the slim scope staging gastric cancer. I must start by saying that actually in the UK practice, we really wouldn't normally use EUS for purely gastric cancer staging. We probably would rely on cross-sectional imaging. Obviously, if there's any involvement of the gastroesophageal junction, then we would always do EUS. But this is a gastric ulcer, as you can see, on the greater curvature with a slough in the base. And to look at that with EUS, probably what I'm going to do is I'm going to probably put a lot of water into the stomach to try and get a better image of the mucosa. I don't want to bang into this ulcer too much, or we might be doing some retrieval of some bleeding. So you can already see that there is a lot of mucosal and submucosal thickening just near this ulcer. But at the moment, I'm going to leave that for a second, because I'm just going to come back to the liver and just check out the proximal part of the liver. I'm just looking through the proximal liver. There is obviously the cystic lesion within the right lobe of the liver, which is slightly out of our range. It's quite close to the IVC. I think the cross-sectional imaging that I saw very briefly. I've been told it's confirmed as an hydatid cyst, so we don't need to really be worried about that. So I'm not going to waste too much of your time and get you out into the sun quicker than otherwise. So I'm just looking. EUS is absolutely fabulous at looking for small liver metastasis, and we haven't picked up anything in the proximal liver. So then
they're pretty rare in gastric cancer, don't you find? From EUS, I don't know why, but I think I've ever seen liver mets from gastric cancer.
Yeah, we do pick them up for lung cancer. Actually, surprised. I do a lot of lung cancer
staging.
Yeah,
lung cancer, pancreatic, gastric. I don't know why.
Especially with this early lesion, I think. So we're just going to look at the celiac axis if we can. So I just want to magnify that image slightly. I've got my colleague here. So you've got the crus of the diaphragm in front of the aorta there. And we're just going to come below that and see the origin of the celiac axis and the left gastric artery going cranially, just to see if there are any nodes going up towards the gastroesophageal junction. And I can't see any nodes in this area at all. So this seems to be node-free. We're going to just go down now to the ulcer itself, which I think is important to get on and show you that. If I could have some water to put into the stomach, please. That would be great.
Well, one of the things, though, don't you find, I mean, I'm surprised you say you don't do EUS for this. I find it rarely changes management, but EUS appears to be more sensitive for small amounts of ascites that you can't see by CT.
Yeah, I mean, I agree with you, but my surgeons are very dogmatic, and they would always do a laparoscopic assessment and staging. So really, I mean, when I suggest EUS for gastric cancers, I get very short shrift, and they don't tend to be interested, which is great because we've got enough work. So, but certainly the patient would have a laparoscopy.
That's probably a better approach, actually.
Well, the other thing is, of course, that it's a great, a lot of these patients have a lot of comorbidities, and it's a very useful way of assessing their ability to tolerate a resection if they have a laparoscopic assessment first. So we're just going to try and work our way up towards this ulcer. I mean, the trouble is it's just a large ulcer cavity, so it's going to be quite difficult to get a very good image. So here's the ulcer cavity, you can see, but of course it will have some gas within it. Which is the enemy of EUS, as we know. And what we've got to do here is we've got to see the, could you just magnify the image slightly, and we're just going to try and get rid of that artifact that's just in there. It's amazing how often the artifact is actually on the crucial bit of the image. That's radiology for you. But we're just going to have a look here and see whether or not there's any approximation or penetration of the muscularis layer. Of course, in this circumstances, there's going to be a lot of inflammation here. And, EUS can be confused by that. there is some irregularity on the outside surface there. So I would like a bit of a vote on what people think, whether that's, I would certainly say the muscularis is involved, therefore it's definitely T2, but it's whether it's T3 or not at that level. Anand, what's your thinking?
So we have a nice modality, which is elastography, and inflammation is normally pretty soft and cancer tissue is pretty stiff. Why not using elastography?
I would entirely agree with you. The only problem with elastography, when you have a big ulcer, you have a big ulcer cavity, you might get a lot of artifact around that. Because, of course, you can't have the elastography over the cavity itself. But I can just try and put it there. I'm going to try and keep still. It's all about keeping a stable image. Yeah, but I would suggest that actually to try and get a straight track on this ulcer is going to be quite difficult, but we will attempt to do that.
Well, as far as the staging, according to the AJ, the American Joint Committee on Cancer, the latest classification, all of you know, but for the residents and the students in the convention, or people who don't know much about the staging of gastric cancer, T3 is basically when you have the involvement to the subserosa. T4A if you have the involvement of the visceral peritoneum, and the T4B if you have the involvement of adjacent organs or structures. So the question is this is a T3 or this is a T2? And so far it looks like a T3, at least from what I saw, but we didn't find any lymph nodes yet. Nick looked at the celiac axis and there are no lymph nodes. He looked at the liver. There's no evidence of metastatic lesions. There is no ascites. We looked at the adrenal gland and appears fine. So far it appears to be from, at least at this point, T3 and 0.
There's some very small nodes here. Yeah, there are one or two small nodes here.
That's a...
So we've got two...
I have seen some cases with mediastinal nodes as well.
Yeah, we're going to look at the mediastinal.
Don't worry, we're going to come back. Yeah.
I think this is a lymph node. We can...
So normally with this, in this area, I mean, with such a deep ulcer as well, you're going to get a lot of reactive lymphadenopathy.
This is a 6 millimeter.
Yeah.
Is that the lesion is a T3, because T3 lesion in the stomach should receive a neoadjuvant treatment.
Yeah, and I think it is T3. So.
No,
Okay.
After it's a T3 and 1 or T3 and 0, I think it's the same.
Yeah, but that's two lymph nodes.
There is no change in the
management,
in the therapeutic decision making. The only thing is if you find nodes in the mediastinum, this will change dramatically the staging of the patient.
Okay, so I'm just going to come back into the mediastinum, and of course, just up to the level of the left atrium, which we can see the mitral valve here between the left atrium and the ventricle. I must say the ventricle in this patient is quite dilated, so I wondered if he has a degree of heart failure or cardiomyopathy. You see that you don't normally see such a floppy ventricle beyond the atrium. Mm-hmm. That's quite an unusual mark. He has quite a lot of ventricular dilatation. So here we now have the aortic valve behind the left atrium, and then the pulmonary outflow trunk. And then coming proximal to that, we will then be in the subcarinal area, so station 7 for lung cancer workers. Just increase the depth now, reduce the depth, increase the mag, please. Increase the magnification. Thanks. So here you have the classic appearance of the carina, and there's no nodes at all in that area between the atrium and the carina. So I'll just turn the scope now over to the aortopulmonary window. And he's got a little bit of unfolding of the aorta, as you would expect. And so here we are. This is the aorta, this is the pulmonary artery, this is the AP window. So he has no significant lymphadenopathy in that area. Of course, we then come up higher, so-called level 2 nodes for lung cancer staging. Here is the aortic arch. And just there's the first of the vessels. That's the left subclavian artery. So we're just going to look at this level. And the idea at this level is just to rotate the scope fully through 360 degrees to ensure you're not missing any nodes either to the left or the right of the midline. Quite often, there's the spine. You can sometimes pick up the azygos vein on the right side. Here's the azygos vein on the other side, and that's quite useful. Big azygos vein. He's got a lot of heart issues, this patient.
Can you explain?
He's got
hypertension.
He's got a very dilated ventricle. I think he's got left and right heart failure. So he's got a combined congestive cardiac failure. So
cardiac failure. Huh?
So this is the
Yes.
azygos vein as it dips towards the SVC. And obviously for lung cancer staging, the nodes above the azygos vein, it's a very important divider, would be level 4R nodes. But you can see here the pleural lining is very closely applied to the azygos vein, and there are no nodes there. And just higher still, coming up to level 2 nodes, nothing here. So he hasn't got any significant mediastinal...
So your final staging
So
is T3
in summary,
and
it's
N1.
T3, N1, and he has a lot of incipient heart failure.
Okay,
oh,
thank you very
you want
much.
to take the-
Very nice.